Good morning to everybody joining us from the UK. Hello to everybody else from the rest of the world. Today we have a very interesting session lined up for you. This is Mr. Amit Vats. He is an orthopedic consultant surgeon, and he has a lot of experience in research. He's going to give us a very interesting session about qualitative research. We've already covered about quantitative research before and the introduction to methodologies. Highly recommend to watch those videos if you haven't already. Mr. Vats has done a PhD in teamwork and safety in surgery from Imperial College London. And he's prepared a very good session for you today. Now, over to you, Mr. Vats. Let's begin.
Hi. So you've already had an introduction about me. So I'm a clinician primarily. And just putting up the slide, bear with me for a second. So I'm a clinician working in the NHS. And today I'm primarily going to talk to you about qualitative methods research. So in this session, we're going to talk about why qualitative research is relevant to us, to distinguish between qualitative and quantitative research designs, their benefits and advantages, one over the other, introduce specific strategies of conducting research, how to describe the research questions, and how to go about doing qualitative research, and understanding the principles behind it, to understand the methodology of ethnography, which is one of the main pillars of qualitative research, and then to critically reflect on the quality of qualitative study, and then to understand mixed methods research. So I think the primary question, why should we be interested in qualitative research? I started off as a clinician, primarily looking at numbers, as we all do. A lot of studies looking at different clinical outcomes which are correlated, delving upon statistical analysis. But I realized that more and more as I'm deep into the clinical practice, qualitative methodology is what I probably use more often than quantitative methodology in my day-to-day practice and to improve my clinical practice. So that's where I see the relevance of qualitative research. So what we are talking about is about learning objectives. So these are the learning objectives that I just mentioned. And then we're talking about why qualitative research. So if we look at qualitative research, it is essentially a methodology, an approach, or more importantly, a strategy to systematically collect, organize, and analyze text. So all the important principle is that not everything that you can count is important, and everything that is important may not be countable. So the side of important that is not countable, the way of describing that and analyzing it is with qualitative research. So talking about research design and strategies of inquiry. So there are different ways of describing any strategy inquiries. Either it can be secondary research, such as a systematic analysis or a meta-analysis, or a field study, which is essentially primary research. They can be exploratory in nature or causal, looking at cause and effect. And if we exploratory can be descriptive, who, what, where, when, and explanatory, why, and then looking at direct cause and effect if we know that there are specific defined variables that may influence the outcome. For example, cigarette smoking and lung cancer. So qualitative is predominantly on the left side of the spectrum, which is essentially looking at understanding when there are too many variables, to find any direct cause and effect. So I see qualitative and quantitative not as defined, isolated approaches to research, but there's a confluence, it's a continuum, and in between we have mixed methods. So on the left, we see the key tenets of qualitative research, and on the right, we look at the important aspects of quantitative research. So qualitative research is more about describing, analyzing words, text, pictures. It is more about inquiry into meaning, experiences, behaviors, and essentially looking at a problem from within. So it is very good at describing a group of practitioners, for instance, in the operating theater, for example, to understand their cultural practices and what influences those, as a result of which there may be a predefined outcome. So research questions are changeable and open. So one goes about qualitative research with an open mind. It's not a predefined methodology, or methodology is predefined, but the methods may not be predefined, and the research questions are more open. Whereas on the quantitative study, as you have previously listened to in the sessions, it's more about disproving and proving null hypotheses. So inherently qualitative studies are inductive, whereas the quantitative studies are deductive, and it follows a set pattern of inquiry, whereas qualitative is more flexible in its approach, and it is guided more by the findings that we come across, rather than answering one particular question specifically through a particular specific predefined, almost law-like predescriptive relationship between measurable variables. So again, we see qualitative and quantitative. We can do studies which are purely on one side, or we can do studies which are mixed in nature. So on the qualitative side, these are some of the examples. So ethnography, participatory research, case study research. And on the quantitative side, we have experiments, trials, and surveys. So talking about ethnography, which is the main system of inquiry in qualitative research. So it is derived from words ethnos and graphos, which is people, and to write. So it essentially is a study of cultures, of people, of groups, and also a process of fieldwork that researchers do, through which they immerse themselves in the life of a local culture. And in healthcare, from healthcare perspective, it may be looking at the cultural practices within a healthcare system or a group of practitioners. So now let's talk a little bit about the difference between methodology or methods, or rather links between them. So methodology is the principal strategy that guides your research practices. It's a plan of action, a process that you are going to delve into the inquiry of a question, and methods are the tools that you're going to use to stick to that methodology, which may be either a literature review, it could be a clinical trial, or qualitative methods, which could be an interview study or a focus group. So in this table, the top row is talking about the different types of research methodologies, or types of research. And the second column is talking about the research methodology, which can be experimental trial, survey, case study, ethnography, or a mixture. And then the third row is the methods that one can use. For instance, for quantitative, they can be studies, which may be randomized or blinded, survey questionnaires are structured, or interviews which are structured and have got predefined responses. Where on the qualitative side, there may be observations, field notes, focus group sessions, and semi and unstructured interviews. And then again, quantitative research is heavy upon relies upon statistical analysis of the gathered data, whereas qualitative essentially is about collecting the text, as I previously mentioned, organizing it according to the methods, and then doing a thematic analysis. So this is just a short exercise for the participants. So I'm using shooters as an example. So as you can see, there's a bullseye chart in front of you, 3 of them. So if I was to ask you, of the first, second, and third shooter, the bullseye charts that you see, if I was to ask you which shooter is more reliable, which shooter is more valid or true, and which shooter is more both valid and reliable out of the 3? Okay, so if we look into it, the first shooter is poor in both reliability and validity. And the reason for that is that some of the shots are closer to the center, others are widespread, and they're all over the place. So we are essentially, from the research perspective, getting some answers to the questions that we are asking, and some answers which are neither answering the question and are all over the place. Second one is reliable at not answering the question being asked, but they are the answers are within the same area. Whereas the third one is able to answer the questions or shoot right in the middle and more predictably. So again, so if we look at these key concepts, validity, generalizability, reliability, and random sampling. So rather than give you the definitions directly, I have jumbled it all up. And if you'll take a moment to think as to which statement truly represents the concepts in the left column. Okay. So if you look at strategy of selection of participants, where members are selected by chance, with each having an equal probability of being chosen, is random sampling. Findings can be generalized beyond a research setting that is relevant, applicable to other settings, is generalizability. Extent to which the measure process is dependable and consistent is reliability, and the extent to which the measure adequately represents underlying construct that is supposed to measure is validity. So if we think about qualitative and quantitative research, they are not two separate identities in terms of how we go about analyzing and assessing or designing a research study. They all follow the tenets of validity, reliability, and generalizability in most cases. And a well-designed, well-performed qualitative method research should be reproducible. So let's talk a bit about sampling in qualitative research. And as you can see, the purpose here is not to achieve statistical representativeness or generalizability to ensure selection of information-rich cases. The purpose is not to achieve statistical representativeness, but generalizability, and to ensure selection of information-rich cases. So essentially, for instance, if we are doing a interview study or we are doing a focus group session, we need to recruit participants who are more likely to give us an enriched insight and better information. So sampling can be the typical or extreme. So essentially, if we talk about, for instance, hip replacement surgery, and if we say that the rate of dislocation after hip replacement surgery is about 2%, then if we are inquiring into the experiences or pain or quality of life of patients who have had a good outcome, which is in 98% of cases, so that will be typical sampling. But if we are focusing on the 2% who had adverse outcomes or were outliers, then that will be extreme sampling. The next type of sampling is snowball sampling. So essentially, this is quite commonly used in interview studies, especially if the expertise of the participants is not that widely known. For instance, if we are talking about surgeons' experience of managing stress while doing complex revision knee surgeries or choosing patients for complex knee surgery, we may be able to identify one surgeon who does it, interview the surgeon, and then be guided by that surgeon to direct us to the next participant of the study. Then it can be purposive or judgment sampling. So essentially where we can choose our participants, for instance, to understand the delays in operating theater efficiency. We may be wanting to speak to nurses, but we only want to speak to nurses who have got more than 10 years of experience or who work, for instance, only in specific theaters such as trauma theaters. So that will be purposive sampling. And then if we are collecting samples, recruiting patients or study candidates randomly or to represent the usual population, for instance, all patients coming to a clinic, then that will be a homogeneous sampling method. Key approaches in qualitative research. So again, important thing is to understand and design your question well, because what question you want answered will guide what is the best methodology in terms of quantitative or qualitative, and also as to what will be the best method to go about gathering data and the sampling technique. And then again, there needs to be a system of systematically analyzing the data that you receive. Either it can be done manually using spreadsheets, or now there are softwares available which can help do that, such as NVivo. And again, the important thing with qualitative studies that we are capturing people's perceptions, thoughts, ideas, lived experiences. So the quotes that we are going to use to analyze the data, they should be directly traceable back to the subject or the participant. So again, ensuring quality is important. So talking again about validity, analyze the data in terms of what the answer really means and what is being questioned rather than the researcher's perspective or interpretation of what the interview participant has actually said. Again, choosing the informants or sample participants carefully, testing against a variety of cases, and more importantly, triangulation, which is essentially using other data sources, which may be previous literature or audits to triangulate that the data that you're capturing is reliable and it is in line with what is expected. Again, field notes is another way of collecting the data in observational studies. So again, one needs to think about how you are going to collect the data, whether you're going to collect the data. For instance, if you're performing an observational study in a clinic or in an operation theater, you need to be able to understand and make a decision whether you're going to document and take notes simultaneously or do it in retrospect. Because obviously, if you're doing it retrospectively, then one has to think about the recall bias as well. And then if we are doing an interview study, we need to think about whether we are going to take down the field notes verbatim or more of an interpretation at the first instance as to what the other interview candidate has said. What are we documenting? And field notes are always a balance between expediency and representativeness. So essentially, we need to ensure that we are able to capture all the relevant data and also ensure that what we are capturing is a true representation of what has actually happened. So let's talk a bit about examples of qualitative and mixed methods research in order to understand how to practically apply the theoretical concepts that we have just talked about. So I'll take, for example, the World Health Organization's WHO Surgical Safety Checklist study. So some of you may be aware of this or may have seen this checklist, which was essentially designed under the umbrella of the WHO to reduce the risk of complications or avoidable complications in surgery, and this was piloted at a global level. So this was the intervention and it was piloted. So I'm just representing the UK data to you, which was collected a pre and post study. So where data on processes where the patients had antibiotics, whether they had a temperature check, whether they had their consent form and identity checked before surgery. After a phase of initial baseline data collection, the intervention, the checklist was implemented, and then similar data was collected. Data was also collected on outcomes to look at complications and length of hospital stay, blood loss. So as you can see, these were the results from the UK side, but this was a global study. So similar results were published in the New England Journal of Medicine, which showed that the surgical site infections with the checklist reduced risk of other complications such as bleeding, risk of reoperation, etc. That's also reduced. And it also showed a reduction in death rate. So this, in the outset, it looks like that this is quantitative research. Well, it is, but not quite. If we just reverse the process a bit, sorry. Okay, let's delve upon the checklist. How did that come about? And this is where the qualitative research comes into action. So this intervention was designed using qualitative methodology. So essentially, 50 experts in different fields of medicine, surgery, anesthesia, nursing, infection control, healthcare managers, they were all brought under the umbrella of WHO, and working groups were formed and focus group sessions were held with these experts to identify what were the key problems with surgery, what were the key complications, and what interventions could be designed to mitigate those complications. And they, after that focus group session, thematic analysis of the text and identifying the themes that were identified in those focus group sessions. At the end of it, the experts came up with this surgical checklist. So this is qualitative research in order to arrive at an intervention, which subsequently led to the quantitative study. Now, this is an interesting graph that I'd like to present. So this is the use of, this graph shows the use of surgical checklist when it was implemented in a large United Kingdom hospital in London, which showed that as the researchers were conducting the study and driving the checklist study in the operating theaters, its use arose in March and April. Then subsequently the results were published, and it showed at a global level that the checklist improved clinical outcomes. But we noticed that over the following months, the use of the checklist dropped down. So this was quite interesting. We wanted to understand as to why, despite showing a clear improvement in clinical outcomes with the use of checklist, why did the compliance with the checklist dropped? The last bit, the August column that you see, that's because at that time the researchers went back in order to drive the checklist, and then its uptake increased again. So we wanted to understand why the compliance with the checklist dropped and how to make it resilient in the long term. So for that, we had to design a qualitative study in order to understand the cultures within the operating theaters, which were motivating or demotivating people from using it. So therefore, this I'll describe to you the interview study that was conducted in the following months, which was essentially carried out using semi-structured interviews. So we designed a topic guide, which was essentially a list of questions that we wanted to ask the respondents. These were open-ended questions where the answers were likely to be not just simple one word yes or no or a number, but more likely to give us, for instance, what were the barriers to the use of checklist in the use? Was the checklist relevant to the UK perspective? How can we improve upon the checklist so that its compliance improves? So I'm just giving you some examples of the question on the topic guide. The technique that was used for sampling was snowball sampling technique. So we recruited initially the few surgeons and nurses in one operating theater. And then from one surgeon or nurse referred to the next one who might have had more insight or input according to them. So this was the snowball sampling technique that was used for this. How many participants do we need to take? Well, this would depend upon the thematic saturation. So essentially, it is that we kept on recruiting participants and asking them questions and collecting the data and organizing it into emerging themes. And we continued this process until there were no new themes emerging. And it took about 45 participants to arrive at thematic saturation in that particular hospital. So these were 30 to 45-minute interviews. They were audio recorded, and the researcher also took hand notes simultaneously. The audio recordings were transcribed, and then the transcripts were cross-checked with the participants. So again, this is about cross-checking for validity, that we are gathering the information and understanding the meaning, what the interview participant meant, rather than the researcher. So thematic assessment was performed using qualitative assessment software. We used in vivo for this. This can be done either using a spreadsheet or using specialized softwares. And then multiple themes emerged, which helped us in tweak the checklist, add and improve on it so that it could be more relevant to the NHS theatre staff. So for instance, this is the checklist which was modified as a result of the interview study. And currently this study, since 2012 now, has been in use in the United Kingdom. And in fact, it is now mandatory for all operating theatres in the United Kingdom. So these are the bits that were added after the interview study. So again, from the interview study, it emerged that while the global study with the WHO checklist, for instance, it showed a clear benefit in terms of patient outcomes, but that benefit or those improvement in clinical outcomes were not statistically significant in the quantitative study that was carried out at the UK pilot site. And the reason being that in order to show a small improvement in mortality, for instance, which is in UK operating theatres for elective surgery already less than 1%, the number of participants that would have needed to have gathered data on would have been more than 5,000, which was not possible in a short duration of time. Therefore, we, in order to understand how the checklist improves the efficiency or the safety in the operating theatre, we wanted to conduct a qualitative study. And this was a theatre observational study, which was using field notes, again, ethnographic mixed methods research. So we collected field notes in the operating theatre by observing surgeries, identified and documented the events that happened in the theatre. For instance, whether there was any communication with regards to antibiotics, whether the surgeon had to wait for some specific instruments, were there any equipment problems for which the nurses had to run outside the theatre to get a particular equipment or instrument, were there any complexity in the surgery. So everything was documented by real-time observational study, and field notes were taken by the researchers by hand. And then subsequently, these field notes were put in an Excel spreadsheet in this situation, and they were put under various columns of different themes. For instance, we looked at teamwork failures, So whether there was any failures which were related to communication, whether there were any failures that were related to situational awareness or shared mental model, whether there was any patient harm or any delays in the operating theaters, and what was its direct impact upon the patient or the running of the surgery in terms of delays in times of minutes. And then subsequently, statistical analysis was carried out, and correlation coefficients were calculated. So these were the results. So observed 20 cases, which was 140 hours of surgical observations, and we noted 364 failures. Majority of them were teamwork failures, about 60% of them. The pie chart on the right side shows you the different kinds of failures, and you can see that a lot of them were non-technical failures, but there were some technical failures as well, and equipment failures. And the correlation analysis subsequently showed that non-technical failures or teamwork failures lead to equipment problems in the operating theater. So we had a framework which was now validated, which could be used to assess whether things improve with the checklist use or not. And this is precisely what we did in the next study, which was essentially using this ethnographic methodology with field notes to study the theater environment. We assessed the use of checklist in the theater in the subsequent studies, and using the methodology developed in the previous study, we analyzed what impact the use of checklist had on these failures, and what was the impact if the checklist was done well, or if the checklist was not done so well. And this is what we found, that the quality of checklist use correlated well with the equipment failures in the operating theater. So if the checklist was used well, we showed through statistical analysis that teamwork ratings and perceived benefits of checklists in the eyes of the participants also improved. So here you can see that the framework of data collection was qualitative. Themes were identified and analyzed in a qualitative way. The instances were numbered, or the events were numbered, and therefore we were able to conduct statistical analysis in terms of correlations between one type of failure and the other type of failure. So for in this instance, whether teamwork failures led to technical problems or patient safety harm, patient safety concerns or harm, or equipment failures. So in conclusion, we see that the qualitative research is useful in understanding the microscopic level processes in a healthcare setting. Their assessment and design should be keeping in mind of the core standards of any research, which is validity, reliability, and rule out biases. And mixed methods research is a very powerful tool in healthcare, especially if you want to improve the quality of service that your trust or you as a clinician provide. Thank you. Any questions?
Please put in your questions on the chat group, the group chat. If you have any questions, we're happy to answer them. Okay, we have one question here which says, what are the ways in which we can make sure the qualitative data collected is valid?
Okay, so two primary things that one needs to keep in mind. First one is, for instance, if we are looking at interview studies, I'll use as an example, same is relevant for focus group sessions as well, is that once we collect the data, that is, we have collected the text or the opinions or their answers to questions, then once we have transcribed them, then our interpretation of the data should be cross-checked with the participants. For instance, it's much easier in an interview study, but by taking back the transcripts to the participant and cross-checking with them whether the transcribed information truly represents what they meant. And second, for instance, in focus group session is to summarize the key findings with the participants of the focus group at the end of the session. This can also be done by, for instance, in focus group session is to allow the participants themselves to collate the thoughts and data rather than a researcher doing it on their behalf. For instance, using sticky notes, which the participants can write themselves and put into various themes. So essentially, on a board, you can develop and design a thematic chart or a spreadsheet, which can subsequently be transported to a spreadsheet. So that's one. And the second one is translation, which is essentially to cross-check the information that one has gathered with the current evidence in the literature or, for instance, findings of a study that you've done, and also the data that you gather from other participants and informants. Okay.
All right. The next question is, what are the main challenges in performing qualitative research in surgical specialties?
Very interesting question. For instance, with this WHO surgical checklist study, which I performed as part of my PhD, the big challenge we faced was cultural, and also the trust. So essentially, you are an observer. You are collecting data. So if you are doing video recordings or audio recordings, so there has to be certain trust between the researcher and the participant. And that can be quite hard, especially if you are looking into a subject matter which may be sensitive. So I think rapport building is probably one of the biggest challenges. Focus group sessions are less interpersonal, easier to do. Interview study and direct observational studies require more trust and relationship building between the participants and the researchers. So I think the big challenge here is trust.
All right. Next question is, what would be some resources or references we could go through? Also, do we use some special software to do qualitative research?
So, so from a healthcare perspective, so for instance, for our day-to-day practice, a lot of us do clinical audits on regular basis, especially in UK. Every trainee or every clinician, for that matter, is supposed to be doing clinical audits of quality improvement exercises every year, at least one every year. what the qualitative studies or qualitative methodology can help you do better is to design interventions. So audit study may be able to show, for instance, whether our rate of infections after a hip fracture surgery is good as compared to the national standard or the gold standard or not. If we see that after hip fracture surgery, the patients who have got high protein level in their blood do better than the ones who don't, for instance. And then we want to institute interventions to improve our practice. So in that case, so I think the qualitative methods here can be used as an investigative tool to design interventions better so that they are more likely to be resilient and work for a longer term and actually bring about the change that you want to bring about. So for that, using simple Excel spreadsheets is more than sufficient, because the themes that you're identifying are not too varied. If somebody is doing more complex interview studies, then there are specialized softwares for it. So I use NVivo for it, which is a good software for identification of themes, because you can upload your transcripts, for instance, on the software, and then essentially it can, and if you give keywords, then it can identify different themes that are arising from those interview studies. Hope that helps.
All right. Next question is the reproducibility of qualitative research biased with perspective of the case participants, and how can we reduce it?
Very good question. I think, like any study, biases are problems, both for qualitative and quantitative study. The qualitative study, yes, can be biased from the participant perspective. Therefore, in order for the study to be valid and reliable, you need to interview or involve in a focus group all the participants from all spectrums of the cohort, essentially. So if we are trying to find a solution to one particular problem, or for instance, whether the patient, how the patient, what menu, for instance, in a hospital should a patient be getting for food, we need to be able to gather information from participants who are who may have one fixed idea or one fixed cuisine preference, but also take into account others. So the idea is to gather, recruit participants from all spectrums rather than focus on just one spectrum, one side of the spectrum. So that's one. And second is the bias that is associated with the researcher. So the important thing is, again, with the question, design your question well. What is the question you're trying to answer? And do not have preconceived theory or preconceived hypothesis, and then try and prove and disprove it with that question. So you have to go in with an open mind.
All right. The last question is, what is the difference between quality improvement projects and qualitative research?
Quality improvement, so repeat the question again, sorry.
So it was asked by the same person in two different questions, which is quality research only limited to improve the quality of service provided? And what is the difference between a quality improvement project and qualitative research?
Okay. So qualitative research is a strategy to gather, organize, and analyze data that cannot be measured in terms of numbers. Okay, so any problem that one has which cannot be quantified, we have to use qualitative methodology. Usually it is to understand the perspectives or behaviors and cultural practices, and look at the root causes or underlying factors. For instance, why if a particular set of trainees is underperforming, or students are underperforming, then numbers will show us that which trainees are underperforming. But if we want to investigate why they may be underperforming, then we have to take up qualitative research methodology. And again, with the quality improvement activity. So quality improvement activity is essentially to improve our practice, to align our clinical practice, for example, with the gold standard. So while the quantitative techniques of numbers, averages, statistical analysis will show us whether we are adhering to the gold standard or not, but if we want to design an intervention to improve our results, then we have to take up qualitative methods in order to design intervention. So intervention design, one of the key approaches is qualitative methods.
Okay. All right, perfect. There are a few people who are asking if we could provide with more topics or examples of studies where they can read up more about and understand more about qualitative research. I think for us, it would be possible for us to give a few recommendations out in emails, but if you could mention a few now as well, that's completely fine as well.
So now so BMJ does a few series. So Trisha Greenhalgh has, there's some papers in the BMJ which is talking about qualitative research. That is a very nice paper. I can email you the links later on. I'll have to find it. So as you can see that most of the literature that is there from the qualitative research side is predominantly for social sciences. Health clinicians, although we use qualitative methods all the time, it is the literature which is relevant to healthcare practitioners is a bit limited, but I'll send some links later on, and you can forward that in emails, which I have used to come up with my presentation.
Definitely. There's one last question that's come up now. How can we make sure that the questionnaires we set up for qualitative research are valid?
So that's a minefield by itself. So first process is, how do you go about designing the questionnaire? Okay, so again, like I say, so design of a questionnaire. So we are talking about the internal validity of the questionnaire by itself, which can be addressed to by not just designing the questionnaire with the help of one or two experts, but organizing a staggered focus group to come up with a questionnaire so that it does have an internal validity. For external validity, then one can, so all the questionnaires, for instance, they are questionnaires to assess the improvement in quality of life of patients after, say, hip or knee replacement, the scores. So while they are scores, they are based upon questions. Statistical analysis can subsequently be carried out to understand whether the questionnaire has got external validity. So that's again a big minefield. So I think probably we'll need to delve on that in the quantitative research method section. But in order to design, so from the qualitative perspective, so essentially it is with a focus group session, or to come up with a questionnaire, because that will give it the internal validity and reliability.
All right. Thank you so much, Mr. Vats, for spending your valuable time and giving us such a great lecture and laying out everything so clearly and answering all the questions so patiently. I'm sure we've all learned a lot today about qualitative research, and we all appreciate this great learning experience. Before we end the session, I would like to have a word with all the participants regarding the feedback forms and the certificates. It's a kind and gentle request to all of you to please understand that all of us who are organizing this are also working full-time as doctors, and sometimes we have busy days, we're on call. It gets difficult to promptly respond to every message or email that gets sent to us. The instructions on the email are very clearly laid out in terms of what will make us send out the feedback forms and certificates to all of you on time, which is if you log in with your names and your email IDs, because otherwise there is no way for us to know if a participant has in fact attended the session. And it's a very tedious process to go through every message and every email to see and to check whether in fact somebody has attended or not. So if we could all just be a bit more patient and understanding regarding the whole process of issuing the feedback forms and certificates, and please understand that it would not always be done in a day or two. Sometimes it might take a week or more, depending on how many participants we had. We have to issue every certificate one by one and send them out to you individually. It takes a bit of time, but rest assured that if you have attended and if you have followed all the instructions clearly, it will be sent out to you definitely, like I'm sure all of you have already received. All right. So yeah, that's it. Thank you all for participating in the session today morning. Looking forward to seeing all of you in the sessions that are to come. I hope you all have a good day. Thank you.
Thank you very much, everybody. Bye-bye.